also. So I'll invite now Dr. Debashis Dutta for the keynote address for this session. And Dr. Debashis Dutta is a very well-known cataract surgeon and a very prolific cataract surgeon. Seen him many times. His presentation, beautifully he does all these techniques, and he's going to talk about refining the refractive outcome in monofocals through trifocal ions.
Thank you, sir. Thank you for the nice introduction. It was very kind of you and for your kind words. Basically, after these heroic surgeries and delightful surgeries, what I'm going to present is going to be somewhat boring to you. But please bear with me, and you can stop me and go to the keynote address. You can ask me questions. So I'll try. After these surgeries, you need to put in an IOL. That's the final goal that we should do. So after all this, what you have done, find that the refractive outcome is very important also. Nevertheless, the surgery has to be done very well. So we try to achieve perfection. But perfection is somewhat elusive. It's something like a mirage. So if you're in pursuit of perfection, what we achieve is excellence. And if you achieve excellence, you deliver good to your patient, and patients will bless you. Why the patients will bless you? Because you have improved their quality of life by giving him the right kind of IOL. And you have reduced his or her spectacle dependence, improving quality of life. So first of all, you should know your subject, not a patient. He's a subject because this is not a disease what we are dealing with. I would like to call him a subject. So what does he do for his living? Or what are his or her hobbies? He's a goldsmith, a sportsman, or a hardcore IT professional. Does he like glasses, or he dislikes glasses? Or is a shooter? I mean, in which eye does he take aim? Does he or she drive at night? So all these things, if you keep it in mind, this will help you to come at a diagnosis. Help you to select the proper lens. But before you do anything, you must know where not to do. That will perhaps make us a better surgeon. So anything on the cornea, Fuchs dystrophy, age-related macular degeneration, and there are a multitude of, I'm not going into the details, but there are conditions where you should not use certain kinds of lenses that you should keep in mind. Like in glaucoma, yellow colored lenses are perhaps better not used. Okay. Light goes from outside to inwards, from cornea to the retina. So all the optical media needs to be transparent in proper order. Otherwise, you can't get the proper results. So you have to have the media properly examined. And the anterior surface of cornea is of utmost importance, because this is the interface between the rest of the world and your eye. So that is maximum amount of refraction, whatever you call it, occurs at the anterior corneal surface. So you can check it by pentacam, oculus, Veracin imaging, which will tell you what kind of, if you have any kind of irregular astigmatism or the like. So some diagnostics you need to do, we will go one by one. And what you have to optimize the corneal surface before you take up surgery. Like pterygia. So if you remove the pterygium, wait for 1.5 months, and then you go do a repeat keratometry, and then you go in for a cataract operation, whatever cataract operation, even a regular cataract operation. Dry eye, blepharitis, map fingerprint dystrophy, Salzmann granular dystrophy, all these things need to be taken care of. Particularly with the aging population, suppose you find a prominent Fuchs dystrophy, like I do endothelial count routinely in all the patients, and you find it's pretty bad. The patient will be ultimately leading DSEC or DMEC, whatever. So how will it have its effect on your choice of lens? You will keep the patient up at least 0.75 diopters myopic, because after DSEC and DMEC, the patient goes hyperopic shift, plus power, and plus power is not good. So you can thinking before, for the future. So of the 70% of the patients we operate on, they need some kind of astigmatic correction. So there's a huge potential for improving the refractive outcome of our regular patients by correcting the astigmatism to at least to some extent. That's why you have the whole bunch of companies bringing in toric lenses, normal toric lenses, trifocal toric lenses, and whatnot. So toric lenses are good for the patient. So how do you correct astigmatism? You can correct it at the corneal level where the problem is, they require astigmatic keratotomies, LRIs, limbal relaxing erection, laser refractive surgery, whatever you do. Or you can correct the compensate for the corneal astigmatism by the IOL, toric IOLs. So a small amount of astigmatism can be taken care of by by having a steep incision cataract surgery, and if it is more, then you'll have to go in for toric IOLs. If it is 5, 6, 7, don't jump after there are custom-made IOLs for correcting 7 diopters of astigmatism also. But before you go in for that, exclude keratoconus. Though it is an aging patient, but irregular astigmatism, don't go for it. Maybe you will be getting that toric calculation has come. Check for any scar in the cornea, which has given this result. So there is, in LRI is an inexpensive procedure. There are various nomograms. If anybody is interested, Fincham nomogram, Napa nomogram, where you can put in that K1 and K2 data, and it will give how much of relaxing incisions you need to give. It is easily available. A poor man's astigmatic correction is temporal SICS. A little bit challenging maybe, but it is not difficult. Any one of us can do it. So you make a comfortable tunnel at least 1 millimeter through from the sclera. If you do it, at least 2 diopters or 3 diopters of astigmatism may be corrected. At least 2. So if you are doing a phaco, if the patient is having a steep axis along the horizontal meridian, you can supplement the incision by the opposite clear corneal incision. And if you are trying to do a proper LRI, so 30 degrees, suppose having the 2 diopters at 180 degree. So 30 degrees for 40 degrees on one side, 40 degrees on another side, you mark it like a toric, and then I have it. This is a guarded knife, diamond knife. You go in for 600 microns depth. This is the 600 micron from this guard to the tip. It is 600 microns. And you gradually incise this area along the limbus just inside the vascular plane. Try not to induce bleeding, but it does not harm if you have a little bit of bleeding. So this is the LRI properly done. You can do the LRI also at the slit lamp also. It's a little bit difficult. And these days you can do LRI with femto laser also, whereby you can have the laser creating the opening for the LRI, and you can open it up. You can make it on 2 sides. First you open one and see the refractive outcome, and you can open the second LRI incision of the femto at a later date. So you can titrate the amount of refractive outcome. And the state-of-the-art machine which the RP center must be having, sir, we don't have, is the real-time aberrometry. So you put the lens inside the eye and see the refractive status of the patient when on the operating table itself. Sir might be able to help us. And you can adjust the lens accordingly on the table, and you don't need to repeat operation. Now let us come to spherical aberration. Normally the corneal, what is spherical aberration? Okay, spherical aberration is a cornea is said to have spherical aberration, positive spherical aberration, which is compensated for by the lens in the young generation, when we were young. Negative spherical aberration. So the effective spherical aberration is 0. As we age, the lens also starts imparting positive spherical aberration. So the image quality decreases. So this is with spherical aberration 0. This is with positive spherical aberration. So this is not wanted. So you see that there is some amount of distortion happening with positive spherical aberration. With positive spherical aberration, you have a staggered kind of focus. Light rays does not come to focus at one single point. So the image is not clear. But in aspheric IOLs, the periphery of the lens becomes somewhat flatter, and you have a clearer and crisper image. So this is the point spread function vis-a-vis the amount of positive spherical aberration you are having. Various companies keep very variable amount of negative spherical astigmatism. Like Alcons keep it 0.2, Technis have 0.27, minus 0.27, Acreol 0. So according to what they find it, according to their study, they keep it. But basically you cannot have it in positive after the operation. Always try to keep it in the 0 to negative, some amount of it. Chromatic aberration, it is the Abbe color, Abbe number of the material by which the lens is made. Higher the Abbe number, better is the chromatic aberration correction, and crisper is the image, and the modulation transfer function. Modulation transfer function is a big chapter. Anyway, next we come to aberrometry. Aberrometry is the total eye aberrometry of the entire system is taken care of, eye trace and oculus, these sort of instruments. Angle kappa is this is the visual axis by which, suppose that fixed at light, what the axis between the light and my macula is my visual axis, and center of the pupil is the pupillary axis, center of the cornea is the optical center. Now angle alpha is between visual axis and optical center. These two, visual axis and optical center. Angle kappa is between visual axis and pupillary center. Now, why do we need to know this? So, when we were putting in a multifocal IOL or a trifocal IOL in the eye, the central ring has to be properly placed vis-a-vis the pupillary location. So, and this is a dilated pupil. What I do, I put a little bit of pilocarpine at the end of the surgery and see for these reflexes, Purkinje images. So if these three, visual axis, the pupillary axis, and the optical center, they are very close by, then it is easier to center the lens, and the refractive outcome is very satisfactory. But if you have this angle alpha kappa, I mean, these three are staggered, spread over the different area, then the results are not perhaps all that satisfactory. So if it is more than 600 microns or 700 microns angle kappa, then, or barycenter various, or biometry machines depict it in various ways, it's better not to go for premium lenses. Now, the main point, the selection of IOL power. Previous formulae, they used to have a fixed effective lens position. It is an assumption, but that is not fixed. A myopic eye may have a deep chamber. It may have a short anterior chamber also. So you cannot generalize, have the IOL position fixed. So the variable eye effective lens position, the formulae which takes into this are good. And the basic for IOL master measures a varied amount of parameters like angle kappa, alpha, white to white, AC depth, lens thickness, posterior keratometry. So these are all these. The more the data, the more the number of variables you feed in to your biometry formulae, the better, the more the accurate the results are going to be. So this is up to as of now, Barrett Universal 2 and Barrett True-K. This is a very good. This formula is quite very good. Now suppose you don't have an IOL master, then what to do? So these formulae are available online. Use immersion technique. Immersion technique, can we have a little bit or I'll go fast? Okay. So immersion technique will make it fast as good. Barrett's formulae, undilated is better, and SRKT formula, if you have a one-cock modification, will give you a very, very good result. So Swepsort's OCT machine is good, Barrett Universal 2K is good, and angle alpha more than 0.7, don't do premium IOLs. Which lens? Various lenses are there. Now toric marking. Mark at the slit lamp with the bubble marker or the pendulum marker, or you may mark the 6 o'clock only. Have the cornea dry before the putting in the mark, and don't use viscoat in the eye, because that will viscoat is difficult to take out, and if it stays into the capsular bag, they will cause rotation of the lens after you have put on. And in case of toric lenses, if you have in high myopes, put in a CTR, mandatorily CTR over the lens. That will prevent rotation of the lens in the eye after you come out. If there is astigmatic surprise, there the eye trace gives a calculation how much you will have to rotate to compensate and get a better result. So eye trace has got a software by which it will calculate for you how much you need to rotate clockwise or anti-clockwise from the existing with the existing IOL in the eye to get a better result. WTR becomes ATR, so correct accordingly. And monovision and micromonovision is the best things to go with monofocals. And like glaucoma, few points, glaucoma better to not have blue blocking lenses. In high myopes, try to have a small myopic outcome. And low myopes have excellent computer vision without glasses also. So high hyperopes are ever forgiving, just to keep them a little bit myopics. And post-operative prophylaxis is also important. Cystoid macular edema should be taken care of, and the astigmatic impact of the surgical wounds needs to be kept in mind, and it has to be individualized. Thank you.
Thank you, Dr. Debashis, for the excellent description of trifocal IL and its advantages and disadvantages. And the one very important thing when we are dealing with the astigmatic IL, toric ILs, the landmark which we choose actually is very important, because when you are implanting the IL into the capsular bag, the positioning of the toric marks have to be very well aligned with the marks which you have put before the surgery. And to have these marks visible during the surgery is very important, because many times when you put gentian violet on the cornea or the limbus, it gets washed out. And then you do not have any option, like you have to again either go with the remarking, which is very difficult after the surgery. So what is done is these days what we do is either we mark the cornea with a needle, or you can put a simple linear cut on the cornea at the periphery, just a very small 1 millimeter cuts, and stain that cut. So that cut will be seen throughout the surgery, and even if the gentian violet is washed out, you can see that mark, and then you can align it along with that. That is one point. And second important point with the toric IL is like where to go for the toric IL, whether it's 1 diopter, 1.5 diopter. What I feel is 1 diopter and less is always better to deal with the LRI or CRI. And if it is more than 1.25 diopter, then toric ILs are the best. It works very well, because at least 0.5 to 0.75 diopter you can correct with giving your incision on the steeper axis. You can very well correct, and then put an LRI, you can correct up to 1 diopter easily. Although it's not very accurate way, but yes, definitely, because if you do not want to go in for the toric IL, then this is the best way. And if you have a 1.25, 1.5 diopter, then definitely, because that is not going to be corrected by the LRI, and so you have to go in for the toric ILs. Dr. Satansh.
About LRI, how long is it going to help you? How long? If it goes, how long?
Literature says that there is regression, and if you do it in a young, it is going to regress. But if you are going
because
to do it
we have done LRI, I have done LRI long 10 years back. LRI, I have purchased a special diamond knife for it.
Yes.
But after 6 months, 3 months again, there is appearance, because LRI, then I stopped doing LRI. Either we do LRI with our
depends how much you cut and how much depth you go through.
So at that time, toric lens was not there. At that time, toric lens was not there. But now we have toric lens. We have correction of astigmatism over the incision of the steep axis, and we should use the toric lens. LRI has no use nowadays, because it is going to be disappear very soon.
Yeah, I agree with you that there is regression, but it has got perhaps some role. That's why even flax machines incorporate LRI.
Yeah, at least it has effect for some time, because we have taken money and we will satisfy the patient for 6 months.
No harm done. At least no harm done.
No harm done. That's true. And for 6 months at least he is satisfied. I have got good vision. Then we can blame him that it was your fault that you have again replaced.
Even the world is going for toric lenses. I would like to say that after operation, I would like to have at least minus 0.75 of diopter cylinders in my non-dominant eye, because this negative cylinder ATR against the rule gives you some sort of a pseudo accommodation. You make squeeze some amount of pinhole action with a minus cylinder. Perhaps you will be able to read.
And second thing,
this is not discussed in any forum. We put in toric lenses.
So second thing, once you put the toric lens, you should always examine the patient. If you operate in the morning, you can examine in the evening. If not possible, next day at least you should examine the patient. If there is a rotation, you should not hesitate in taking the patient back to the. We always tell the patient in advance that it might be I might have to reset the. But we don't make him very what is going. We just say okay, chalo, that's देखते थोड़ा lens और थोड़ा घुमा के रखते दोबारा. You should always rotate the lens. Do not hesitate with the rotation. You should always take the next day, because it is very easy to rotate the next day. And you should not hesitate implanting the toric IOL. If you are not doing it, you should start from tomorrow. It is very easy, like a normal thing.
Thank you so much.
Thank you.
Thank you very much. And any question from the audience house? Any question?
Thank you.
Sir, in
Yes.
most of my patients find if they are -1, 1.25 cylinder left, they are very happy.
Yeah, that's right.
That's why he's saying. What he's saying is same thing.
What he
But-
said, the same thing. I agree with
But
you.
Advantage
They
of
are
the
very happy.
advantage
They say,
of-
I can read also. and-
advantage of this is the near vision improves. Always advantage of minus 0.75 diopter indicates the patient has near vision improves. So you are giving bifocal with a monofocal lens.
Correct. They are very happy.
But you cannot do it in each and every case because it is not in hand.
It depends from person to person.
yeah, it depends how you get final result. Actually, that is important because
For one diopter cylinder, nobody ever
They are happy.
But one point, if you are using a trifocal lens, as Saz said, after more than one, you need to put in toric lens. But if you are using a trifocal lens, you have to correct beyond 0.75. Otherwise, trifocal lenses won't work.
yeah,
You have to
try.
also keep everything in mind. Somebody you are giving trifocal lens has got 0.8 diopters of cylinder. It has to be a toric trifocal. Otherwise, it's not going to work.
Yeah, that's why like up to 0.75 diopter, you can very well correct with the incision and then arrive. So not beyond that, whether it regresses or not, but you get the final effect up to 0.75 diopter. Thank you very much. Thank you, friends, and for being here with us in a very odd time. And thank you very